20% of the test is management of care, safe and effective care environment. So what kinds of things do you think fall under that?
Delegation.
Delegation. So we're going to look at a few examples that kind of come from that area, okay? Questions like, which client does the nurse assess first? Okay, so think about just a typical assignment that you've had in one of your clinical experiences, all right? Especially if you're doing your ER or critical care rotations. You can easily take that statement for this category and think of 4 people who really needed you all at one time, and how did you prioritize those people? All right, so you've got a person who has come in with chest pain and they're diaphoretic. You've got a person who has come in with potential stroke symptoms, but they're still oriented. You've got someone who has come in with days worth of vomiting and really needs an NG tube for starters. And maybe your 4th person is someone who is combative and could really use a dose of Haldol. Okay, does that sound like a typical day in the ER so far? Mm-hmm. All right, so which person gets your attention?
Chest pain.
The chest pain, why?
Heart attack.
Why does that matter? Why does it matter if it's a heart attack?
You only have a set amount of time.
Because if you don't get to that person first, that's the one that could die the quickest at this point, possibly.
We know that that person is probably going to die if we don't get in there and correct some things, okay? If we don't get some stuff moving. We've got 60 to 90 minute window tops to try to get some interventions running, and time is hard. Why are we not so worried about the stroke person? Strokes kill people.
But they're still oriented.
So we don't feel like the stroke has progressed very far. We might have a few minutes. And I mean, really, when you break all that down, what does that look like for your next hour of your nursing shift, right? So you're going to see your heart attack person, you're going to throw them their aspirin, nitro, get somebody else to run an EKG. So you're just going to start wheels in motion for that person, get a baseline assessment. And I mean, we're talking not even probably 10 minutes that you're going to be able to look at your person that has a stroke, make sure they're neurologically intact. And you might even be able to put in a couple of phone calls to get that moving and get a neurologist in there and whatever else you need to do, whether it's evaluate them for TPA or have them do a CT scan or whatever. Then, I mean, you can really quickly go in to see who next. So our other 2 people were somebody who was having some psychiatric symptoms, some pretty severe ones, and somebody who was vomiting. Who's next?
I'll say the bowel. No. Well,
Probably the person who's having the other physiological symptoms, so the person who's vomiting everywhere, yeah. We want to get that stopped. I mean, truly, vomiting is not always like a non-issue. Not only are they losing fluid and electrolytes, but if they're vomiting that forcefully, they could have a Mallory-Weiss tear and actually bleed to death. So that's not an issue. You have to go in there and assess before you know more. Whereas our psychiatric patient, we know that this is going to probably follow a set of guidelines. We're probably going to do some medication, some safety things. And if we don't get to them for a while, they're still going to be okay. They're in a safe environment, and we've got some time to think about what we're going to do with them. Does that make sense? Mm-hmm. So that's the kind of question that comes from this category. The nurse questions, which healthcare provider prescription? All right, so one of the things that you've seen on your exams in your courses has been, which thing does the nurse expect to get ordered? Well, that's not your job. You don't prescribe stuff. But it's 100% our job to stop something that's going to harm the patient, or to make sure that whatever dose is given is accurate and is enough and is not too much. All of those things that's all our wheelhouse. So you definitely do have to know which thing you're going to call and say, no, let's don't do that. Even simple things. So one of a patient that I took care of had a TAH-BSO, so she'd had the abdominal hysterectomy, and the resident comes in and orders like milk and mag or something to get her bowels moving. And I didn't give it, and I waited for the attending to come in. Why do you think?
Because
Because of the incision.
they
It's gonna
had
be
some
expected
surgery to the
post-op.
abdomen, so you don't want to give something that's going to rush those bowels and
You don't want
possibly-
to speed up the bowel movement. You want the bowels to wake up pretty naturally. I mean, sometimes we'll leave in an NG tube the first day or so to let the bowels rest and start to wake up naturally. Because if you don't, you can cause an ileus. Now, granted, I knew that the surgeon was coming in within the hour. Now, if it had been a longer time period, then that would have been worth a phone call to make sure that it got clarified. But those are the kinds of things we're stopping. And she certainly wouldn't have suffered death from that, but it might not have been an ideal outcome. So even things as small as that can be things that we have to question, versus the one that we looked at where maybe an enema was ordered for somebody who was neutropenic and thrombocytopenic, and that's not appropriate, and we have to call and get that stopped. The nurse receives report on a group of clients. The nurse assesses which client first. So again, imagine any of the reports that you've heard. How do you know which person you're going to first?
Unstable.
So whoever is the least stable, right? So what kinds of things are you seeing just in a normal report that indicate that somebody is less stable?
Anything that has to do with the compromised airway.
Okay, so if somebody was not clearing their airway effectively all night,
Vital signs out of whack.
okay, so hypoactive or absent bowel sounds. Absent bowel sounds are an emergency.
A hemorrhage, someone hemorrhaging.
So if someone's hemorrhaging, hopefully you're not getting a report on that person. Hopefully somebody's actually in the room stopping it. But yeah, so somebody that maybe had a hemorrhage overnight and their blood pressure's been low and maybe we haven't gotten to give them blood yet, those kind of things. So that is one situation where you might be able to break it back into ABCs or urgent versus non-urgent. And some days it doesn't matter, and those are good days.